at the end, because you have to be here for that if you win the raffle. That's the secret. You can only win the raffle, which are great bags of stuff. We're valued each over $100. So if you don't stay till the end, you get to win this lovely thing if you come back from lunch. All right, are you ready? Can I start? You're good? Awesome. So we're going to start with or without people. How about that? Yay. All right, so some of you have heard our next speaker speak. If you went to the Irvine conference, Elizabeth Prescott, I actually have to read this because I never remember it, is a certified breathing coordination practitioner. Thank you. And vocal consultant. And she is the fourth practitioner in the world to be certified in the Martin and DeHaas breathing coordination, and is the only practitioner in the entire United States. Like, she's it. Although there might be more soon. There will be more soon. So this is really cool because she works both with people who do voice training, like performers and singers, as well as people who have breathing issues, like lupus patients, in working with them to better expand their lungs, able to get more breath inside of them, and therefore, breathe better, which is super important. Did I say that right?
Very nice.
You know why? Because I listened to you speak in Irvine, which is great. All right, so please welcome Elizabeth. I do want to say that we're not going to have time I don't think we're going to have time for Q&A for Elizabeth. So if you have a question for her, please write it on an index card and at the end write for Elizabeth and give us your email address. And then we will answer them via email. I just want to be mindful and get you guys out of here on time. So without further ado, welcome Elizabeth Prescott.
Thank you. Good afternoon, and I'm so happy to have this many people here. I know there are more who will probably straggle in. I did have the pleasure of presenting in Irvine, and I will make the same offer, hello down there, to you all that I made to them, which is because this is not something that's even known, certainly much less covered by insurance, I am at your service. If you are able to get to me in Sherman Oaks, let me know, email me, call me, and we will set up a complimentary assessment, and I will give you exercises, because it isn't something, it's nice if you can continue with the practice with a practitioner, but even one session and having exercises to work on your own is very helpful. And I would also recommend bring an advocate with you to record the session, so you can record the exercises. You can do wonderful things for yourself with just that experience. And having done that and had a few of you take me up on that, last time, I was able to see a greater variety of people with lupus, and as my friend over here said, you are like snowflakes, no two alike, and I was amazed at how different everyone's situation was very different in the manifestation of the illness, mild, severe, and all kinds of different things. It was really kind of overwhelming. But what I did see that was absolutely the same with every single person. They all could have an easier time with their breathing than they were having, and they all had compensations that they were doing that were not helping them. So, for example, in one, I would see something like that kind of a pattern that comes from a fear of not getting enough air, and so there's a pulled breath that's not helpful for that person. Or this would be another one I've seen. And it wasn't necessary. It was not medically necessary for the sound or the effort to be happening. So what I would want for any of you who are dealing with these challenges is to have a different concept of what a good breath sounds and feels like, how easy it is, how calm it is, and that actually will increase the amount of oxygen that is being absorbed into your body versus what we tend to think of as a good breath, which might be one of those that I just showed you. So there's all that. And in the interest of time, I'll get right to, you can read the handout and history and all that on your own. I wanted to play this audio clip. It's a shortened one. The first one, we cut out a big chunk of it because there's a lot of in-between discussion. It's hard to hear. But the beginning sounded very much like this. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. So the subject could only get to about the number 6. The vocal quality was very poor. The inhales were what we would call pulled, like you just heard me doing that. So they were audible, which is not what we want if we can help it. Then this clip starts after an hour of working with Carl Stau for the first time. Let me find the mouse and give it a little click here, and this should...
Mr. Cannon's first session.
And I don't hear it.
1, 2, 3, 4, 5, 6, 7, 8.
Mr. Cannon.
Is that
3
loading?
months later.
No,
That should be playing.
Can I?
Anything.
1, 2, 3, 4, 5, 6, 7.
So
Is Harold back there? No.
I know it by heart. I can probably show you the whole thing. So initially he went from being able to say a voiced exhale of about a second and a half only to, after working with Carl for an hour, it was about 3 seconds long.
We're trying to play this audio clip.
And then
I
after
tested it
working
before, but now I'm not hearing anything.
It was
Mr. Cannon's first session.
vastly longer. It was about 20 seconds longer, I believe, which is huge. And the vocal quality
Okay,
changed
we can have it
considerably
now,
as well. The
Elizabeth.
reason we use numbers is, you may have noticed, here we go.
Mr. Cannon's first session.
And this is Mr. Cannon. No, it'll be fine.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay.
It's at least calm.
Mr. Cannon, 3 months later.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
With the flourish at the end. I love that.
Now this is him 3 months after
President's
this.
popularity
Now he's reading from the paper, which is
staffers
not
are
easy.
Searching for historical presidents to bolster the president's morale. Nothing makes Mr. Johnson happier these days than to hear about another president who is in a worse pickle than he is right now, and White House staffers are vying for the honor of bringing him the bad news of other administrations.
That every time I hear that, it gives me chills, and I've heard it hundreds of times. This was in the late 50s, and just a little tape recorder, which is why it's such poor quality. So Carl was asked to work. Carl Stau was a choral director, quite famous, was asked to work with people with severe breathing problems, basically advanced emphysema in this case. And you can see the before picture of Mr. Cannon, and then this is 6 months later. You see it. There are a few things to notice. His vocal quality improves. The calmness is there's no comparison in terms of there isn't that sense of fear that he's not going to get enough air. And what they focused on was not taking in more air, but exhaling more calmly and more completely. So what we have, but the problem was Carl Stau worked intuitively and didn't know how to explain why what he was doing was working so well. And they tried. There were grants, there were studies, they tried to do all these things. They saw the results, but then when it came to trying to teach respiratory therapists and others to duplicate this, he couldn't do it. He gave up. He was so sought after in terms of a private practice. He just did that, and he said, you know what, no one can do what I do. It's going to die with me. Just, leave it alone. He passed in 2000, and he had decades worth of students who were very devoted and really watched what he did. One of them was Lynn Martin, who teaches functional anatomy and ideokinesis at Tisch, NYU, and knows the body inside out. I say she has X-ray vision because she seems to see exactly, she knows every structure underneath and what's happening. She did, over the course of 20 years, the analysis to figure out what was working that Carl was doing and why. So that's been passed along. She's now 73 and works out of New York. So if you're ever there, work with her. And then the young Robin de Haas is the one in Switzerland who then convinced her to teach him everything, and then they put together this practitioner training program. But I had to go to Switzerland to do this, which is why there aren't other practitioners here until coming up soon. We just had the first training here soon. So there will be more of us. But It takes a long time to get the training because we have to learn a lot of the anatomy and really understand the function of the ribs. Let me show you the animation. And help me, Catherine. So easy. You'd think I can just do that. There we go. This is an animation of Carl Stow, of a moving X-ray, a fluoroscope of his ribs. I think if you're like me, this is surprising to see for the first time. I didn't know the ribs could move down in that direction. And yes, they do move out a little bit when on the recovery, I would call it, on the inhale, but they're not lifting. So what we don't want is that movement to the ribs. It actually, my body so disagrees with it now, it's uncomfortable even to do that. We want to exhale. So if you were counting, for example, you just let the ribs recover, and then it would be something like this. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4. And then you just let the air drop back in without effort. It will come in if you've exhaled enough, not forcing, not to the point of discomfort, but smoothly, and we get the ribs guiding in the right direction. When we studied the shape of the ribs, we actually see they're designed to move this direction more than in and out. So what I want to do is encourage you to be mindful if you're trying to take a breath by lifting your ribs, and try to do less of that. Instead, focus on the exhale and picture the ribs melting down, as I describe it, towards the pelvis, and the dome of the diaphragm is gliding up as that's happening. And if you do that, then you just let the air come in. And I'm also happy to show you in the hallway, or if you come to see me, what that feels like, a dramatic, long, easy exhale that then facilitates a very easy inhale. So those are my two audiovisual bits. So in terms of an actual session, what that looks like is we use a treatment table, something that can get to all four sides of someone. There are stretches for the psoas, believe it or not, which is a muscle quite internal, attaches to the femur, winds up through the pelvis, and attaches to the lumbar and sometimes the lower thoracic vertebrae as well. It will share as neighbors with the crura of the diaphragm. The diaphragm is shaped kind of like an umbrella. It's not symmetrical, of course, but it has a dome in the middle. It's attached to the ribs on the outside, and on the inside, it's also attached. The legs of the diaphragm, sometimes they'll call them, they're actually crura, but these little fibers. And so that fiber from the spine to the to the ribs where it attaches, those fibers of the diaphragm have to elongate as the dome of the diaphragm stretches up and expels the air from the lungs. So what we have here is actually a piston, not a fireplace bellows, as I was taught in my early singing years. So this, yes, your ribs can do this, but when you do that, you're stretching the diaphragm wide. That means it will not be available to push the air out of the lungs very effectively. It can't go up very high in the middle. You've already stretched it this way. So we want to keep the ribs dropped, just hanging, very passive. When we work with the table, we do some assessment to see where you're holding tensions that are not helping you. That can be the intercostal muscles themselves, pectoralis. So those are things that I could easily show someone how to work on yourself. Okay, you can see if this is tight, if I'm holding like this, that's going to lock my upper ribs. If the upper ribs are not available to participate in the movement that we want, then it's kind of a domino effect. If these are locked, these are probably going to be locked as well. When we get those first ribs free enough and we do some tapping or whatever we need to do, and very gentle guiding, this is a very gentle practice, but your body will agree with it and say, oh, I see what you're doing. I did this once as a baby, and you did. So the ribs glide down, the dome of the diaphragm glides up, and that's your piston. Does that make sense? I know we're not all mechanics, and I keep trying to find a good animation of a piston, but I haven't really found one that really translates well for this. But that's the idea. So the other thing is to be very mindful that as much as you can, we want a passive inhale, not a pulled inhale. I had an advanced COPD patient who came to see me when I was just starting my training, and she came with her oxygen tank and her medical helper person. And she said, oh, well, should I take off the oxygen? I said, I don't know. This is not a medical treatment. I'm not a doctor. Talk to your medical person. He said, you can do it. Let's just put you on the oximeter, and we'll watch. Well, while she had her oxygen in, her levels were at around 87, 88. Not great. I mean, not great, but okay, keeping her moving. And she took off the oxygen. We were getting into the pattern of the session, and about 20 minutes into it, we're seeing her oxygen levels rise. She got up to 98, and her helper said, you're at 98. I've never seen you at 98. And she was so excited, and then she laughed, and then she panicked, and then she took a pulled inhale like that, and then her oxygen dropped, and her blood pressure went up. Her blood pressure and her heart rate both went up. And that was great biofeedback for her. And then we got her back calmed down again and got back to the exhale that felt so easy to her and the inhale that felt so easy to her that she felt like she wasn't doing anything. She thought that wasn't enough to just, here would be my reasonably long exhale. I don't know how long it'll be. That's my inhale. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And that's my inhale. And that's all it is. If you were feeling my ribs, you would feel that they do gradually do this. Your lung tissue, when it's healthy, is very much like the consistency of a sea sponge. If you imagine gently squeezing the water out of a sea sponge and then letting it come back in, you need to let it come back in. You can't inject the water into the sea sponge. It's not going to go to all the spaces that you want. So we want to allow the air to come in gently into those spaces. So you need to allow some time for the inhale to happen. Don't rush it. And that is where it is helpful to have someone, whether it's me or if you have an advocate who comes and learns kind of how to help you a little, to just remind you, okay, smooth inhale, that's what we're looking for. So does that make sense a little bit? We're cutting really quickly through all this. But the other thing we're going to look for is that sorry, I'm assuming you're all able to hear me as I'm talking off mic. Watch that the sternum is staying as relaxed as possible, and you might do some gentle tapping just to remind it. So when you're getting ready to take your inhale, you're just going to tell this upper part of the rib cage, I don't need your help with this. Just stay put. It's not locked. It's free to move, but it's not going to lift, because if you lift from here, that's going to, you hear what that does even to my voice. It creates strain. What I'd like you to think of doing instead is focusing on the inhale coming mostly into your lower back ribs, not the belly. You don't have lungs in your belly, but into you have about 70% of your lung tissue is here. And I have literally seen, we see this all the time, people who have even lost an entire lung or a lobe that are having better breathing and more effective breathing than before, because we have a lot of redundancy. You have a lot of lung tissue. If you can learn to make the most of what you have plenty. The challenge is that even if the lupus is not affecting your lungs directly or very mildly, just the stress and the worry can contribute to a breathing pattern that will not be helpful to you. So the sort of the antelope breathing, that is helpful if you have a saber-toothed tiger coming and you want to be invisible for a moment. So that's great for that. It's really not useful for us in any other way. We've all heard the stories of a drunk driver who plows into someone and they're so relaxed, they're fine, but the person who sees it coming, they lock all their ribs and they break all their ribs, or several of their ribs, or that xiphoid process there, because you're locking. So your ribs are there to be pliable. I don't want you to think of them as a rib cage. In German, the term is more chest basket, which is a much better word. So I like to think of a rattan basket, flexible. The ribs, of course, the bones are not particularly flexible, but you have around 100 possible articulations in the rib cage, things that can move. So all of those moving parts create great flexibility in the chest basket. So the ribs, their job is not to just be a rigid cage or to do this. Their job is to be flexible and aid in the facilitating the diaphragm, the dome of the diaphragm coming up to empty, and then this on the other side of it. And their other job is to protect the thoracic organs, which they can only do if they're flexible. It's a shock absorber. So mule kicks you in the chest, you're more likely to, this is going to give rather than break. So we definitely want that pliability in your rib cage. And if you were around me, you would see me very often working on my ribs in this way. They've changed, everything has changed shape in my own chest basket over the 4 or 5 years that I've been doing this. In the beginning, I had very much what I would call a singer's rib cage, and I just thought that was my ribs. So very lifted here. The sternum, the costal arch was quite open and lifted. It's hard to even hold like that now. I had high residual volume. Expiratory reserve volume is actually the part of the air that's left in your lungs that's not really helping you, and that would be better if you could exhale it. So that's what we work on as well, is reducing that where that is present, and then gradually these ribs are able to find their just hanging neutral position where they can really move for you. So that's it, and I'm out of time, but I'm happy to answer any questions. Anyone's welcome to feel my ribs, and I can show you what that feels like. It's really a very different concept than what most people think ribs are what they're supposed to do. So thank you so much for your time and attention. Thank you. Yes, please email me, call me, anything, and I'll be...
Thank you.
Yes,
Okay.
absolutely. Thank you for your help.
Thank you.
Hi, friends.
Do you want to do the one I have?
Okay, last part of the day, which is great, because then we get to do the raffle, which I know you're all waiting for. I'm going to talk over here. So, our last presenter of the day, do I need the microphone here?
Which one is it?
Is Dr. Caroline Jeffries. And Dr. Jeffries is a researcher who has just joined the faculty at Cedars-Sinai doing research in immunology, which, having an autoimmune disease, is super important. And she's studying immunology as it pertains to lupus, which is even better. Lupus LA helps support Dr. Jeffries in her work at Cedars-Sinai, and she also works with Dr. Wallace and Dr. Wiseman and the whole Cedars-Sinai team. So she is part of the Lupus LA family, and also now is a member of the Lupus LA Medical Advisory Board. Did I miss anything?
No, I don't think so.
She has a wonderful accent, which I find completely charming. All right, here we go.
Thank you.
Dr. Jeffries.
Thank you. I have to say I'm really privileged to be standing here talking to you guys about lupus and immunology in lupus. I've been studying this disease for 15 years, from an immunology point of view. And probably about 10 years ago, I hooked up with some rheumatologists, and instead of looking at it as, something that affects the immune system, I actually started to understand how it affected people. And that has really, really driven my research in a very, very different way, trying to understand not just what's going on in the immune system in lupus and, maybe thinking about ways that we can change that, but actually finding out what the real unmet needs are for lupus patients and how we might be able to address them and look at ways that we can change treatments, change the way that you're given medications, the cocktails, and make it more personalized for individuals. So that's where, lupus research is going. And an awful lot of researchers, an awful lot of doctors are really starting to move in that direction and start supporting this. So that's kind of, the new era of medicine, I suppose, in general, personalized medicine. Okay, just a bit of background about me. So I've come from Dublin, Ireland, and I worked there in the Royal College of Surgeons as a immunologist, teaching immunology to medical students, which I did for over 10 years. and also, driving my work in lupus forward. This is how I got to work every day. It was a very serene life. I actually didn't realize, how lucky I was, I suppose. None of us do until we're kind of, till we move, I suppose. But then I, told all my colleagues that I was moving to LA, and this is their image of what it was going to be like. And we all know the reality. And, that's the same in every city around the world. In Ireland, rush hour in certain parts of the country is actually a tractor and cows blocking the road, not actually, a sea full of cars as you see here. Okay, so this is what my students used to look like when they'd think of immunology. Oh, my God, what's happening? What are these things? And it's totally bewildering, area. And, it's a new language for people. So what I spent 10 years doing was trying to turn my students into little Zens. Nice, serene students that would come out and actually understand something about immunology. And what I hope to do today is just kind of bring you through some of the areas that I think are probably the most important for lupus, that differentiates lupus from other autoimmune diseases. Okay, so I wanted to talk about the evolution of the immune response, not from an anthropological point of view, not understanding how, we came from worms to humans, but actually understanding what goes on during your bodies throughout the course of your life. So you start off as a baby, and if you look down here in the bottom, can you hear me okay? I'm pretty loud for an Irish girl. You start off down the bottom, and you don't have an immune response. You only have what you got from your mother, from maternal antibodies that were transferred across the placenta, or that were given to you through breast milk. And basically, your immune system has to be educated. It's got to learn what are the good guys and what are the bad guys. And you spend probably the first 5 years of your life learning those things. And every time you meet a new infection, you get sick, you generate antibodies, you activate your immune system so that the next time you meet that infection, you're never going to have the same disease again. You're not going to get sick again. Except for the flu. The flu virus is a tricky virus. It changes every year. So even if you have an immunity to it 1 year, the next time you meet a flu virus, it's different. So your immunity doesn't recognize it. But the other thing I want you to take home from this slide is what happens to your immune system once it's established. Things affect it, right? You have a baby. Parts of your immune system drop. They become less effective, and that's because you don't want to reject that baby, right? You also stressors, things that stress you, change your immune system. Your brain and your immune system are intricately linked. All of those things can affect it. Hormones. As you're going through adolescence, your immune system changes. And there's this crosstalk between hormones and the immune system that we really, really don't understand. And the vast majority of you sitting here with lupus are women. We don't know why women are more susceptible to the disease. There's a thought and something that we're working on that's suggesting that maybe the hormones, female hormones, are helping to drive a particular part of the immune system that I'm going to talk to you about today. And probably, you've gone through all your life, and then you get to this stage in your life when your immune system goes down. And that's got to be the biggest kind of, bummer of everything. You go from being nice, fit, happy, and then your immune system goes down, and now you're susceptible to all these diseases again. So, that's the shape of it, and that's the course of it. And this, believe it or not, is probably one of the most important parts of, your immune system. Education. Basically, teaching your immune system what are the good guys and what are the bad guys. And I love those photographs. I actually spent my life the first couple of years as an immunologist, knowing everything I do, actually bleaching everything for the first couple of years of my kid's life, and then kind of wised up and said, no, he'll be fine. Him, the cat and the dog and the turtles can all play together. They'll be fine. So what you're doing during that period of your life is you're generating immune tolerance. You're teaching your immune system what are the good things, what are the bad things. You're coming in contact with things in everyday life, right? Bacteria, bugs, your animal dander, and you've got to teach your immune system not to react to those things. So, you know, our bodies are cells, and then probably about 3 times, most of our bodies is actually made up of bacteria and fungi, right? So they colonize every part of us. Our immune system has to learn not to react to them. So that's a central part of immunity, tolerance. And the other thing that we've got to do is be tolerant to our own cells. And, you know what happens when you're not tolerant to your own cells. So these are your immune cells. This is a blood cell. It could be a kidney tissue cell. It could be a cell lining the blood vessels lining the blood vessels. It could be a cell that's lining your lungs. You want your immune system not to recognize it, because if it does, then that's when you get inflammation, that's when you get tissue destruction. And as you all know, I'm going to skip that. That's what lupus is. You know, it's basically a loss of tolerance. Yeah. And, it was interesting as I was going through this. I was like, it's all about tolerance, intrude or destroy. And this is like somebody who's been living in the body for, 20 years, 15, 20 years. And all of a sudden, your immune system doesn't recognize it anymore. There's been a switch that's basically turned off that self-tolerance mechanism. So, what is that switch? What is happening in lupus that basically triggers that switch and makes your body, like, all of a sudden recognize your own cells and tissues as non-self and start attacking them? Well, some of the ideas for this and some of the hints from this come from what we know about what drives lupus, like who gets lupus, the susceptibility to lupus. So we have genes that regulate the immune system, and there's been an awful lot of work that's gone into understanding the genes that might drive lupus. And as the last speaker said, the one thing about lupus is it's so different. Everybody is so different. And the amount of genes that are involved in driving the disease or associated with the disease, there are so many of them. So what we can get from this information is there seems to be pathways in the immune system that are targeted in lupus, and they're antiviral pathways. And that kind of hits with some of the literature that has suggested that maybe environmental factors such as viral infections are triggers for lupus, start driving the disease. And then if you start looking at the patient immune cells, what you find is that actually these antiviral pathways, the antiviral immune defense, is hyperactivated in lupus patients. So this antiviral defense mechanism seems to have gone awry somehow in lupus. And lupus is unique amongst all of the autoimmune diseases in that. There are there's one other that I can think of, Sjogren's disease, which is very closely linked to lupus, that has a similar antiviral kind of response. But all of the others, it's mostly inflammation that's driving this, okay? Actually, guys, if you want to ask questions, please stop me, because I'd be really happy to, kind of discuss any of this as we go. Sure. Okay. Great, no, that's fine. Whichever way you want to work it. Okay, so yesterday when I was putting this together, I was trying to find diagrams for viruses and cells and all the rest of it. So this is, thank God we have iPhones. That's all I can say. This is me drawing. These are my drawings, so you can see the not so happy viruses that are supposed to look threatening. They kind of look sick, but anyway. So I'm just going to walk you through the viral infection process because it will help you understand what's really going on. So here's cells lining the lungs. I just picked the lungs for, because a lot of your contact with bugs and etc. and viruses actually takes place in the lungs. So there's a virus. Now viruses have to get inside a cell. They have to get inside. So these are individual cells. That's the way we draw them. Little boxes with circles in the middle. And the virus has to get in to start replicating, to start making more of the virus. So all of your cells, depending on the virus, all the cells in your body basically can be susceptible to viruses, can be attacked by viruses. Excuse me. So now the virus has got in here, and basically multiplied, and it can go off and infect other cells. So your cells of your body have to have a way of detecting that virus and turning on your immune system to say, hey, we've been invaded, come help, let's clear this, get rid of this virus. And the way that they do that is by starting to synthesize and produce proteins called interferons. Now these guys are really one of the kind of biggest findings in lupus in the last 10 years, that patients with lupus have very, very high levels of interferons in their system. And these interferons are great when you've got a viral infection. What they do is they stimulate the other cells of the immune system. So you've got neutrophils and monocytes, they drive inflammation, so they're activated by interferons. You've got B cells that produce antibodies, right? So they're activated by the interferons as well. And then you have killer T cells that basically work to kill the infected cell. And by doing this, all of this, you've basically got rid of the viral infection. But in lupus, if you have so many type 1 interferons or interferons running around in your body, you've just totally overactivated this whole system. You've got neutrophils and monocytes that are driving inflammation. You've got B cells producing autoantibodies, antibodies against your own self-proteins, your own DNA. And you've got T cells which work to kill and destroy tissues. And not only that, you've actually got, the cells of your body are on kind of heightened alert, as if we're infected. So now your immune system is seeing them differently as well. So the whole thing is a vicious cycle. And, the one thing about type 1 interferons is they drive what we call sickness behavior. You've got a really, really bad flu. You feel like you've been slammed by a truck. And that tiredness, those aches and pains, the fever, that horrible feeling of just been unwell is driven by interferons. So, in a normal immune response, basically, what your body does is turn off that interferon switch, right? Because you've done it. You've basically cleared the viral infection. Now you want to reset the immune system so that you can get everything back to normal. Because you don't want those interferons running around your body for the reasons we just discussed. And my thought on autoimmune disease, in fact most diseases, and I mean this is really, and this is where I started off maybe 15 years ago thinking about lupus. And you can think about it for any disease. Your immune system wants to be in balance. It has to be in balance. If it's not, then if you've got overactivation or underactivation, then you've got disease. And inflammation is driving a lot of this. In the case of lupus, interferons are driving the inflammation that's driving the disease. And you can have positive signals. This is a slide that I give for my research talks. You have positive signals that can drive chronic inflammation. You have negative signals that will switch it off. If you have too much of these, you're going to get too much. If you have too little of the negative pathways, the ones that turn things off, you're also going to get too much inflammation. So all of these are kind of pathways that are looked at now in lupus. And the interferons are obviously something that are of huge interest because they're driving this vicious cycle. They're breaking tolerance. They're the proteins that are basically making your immune system now recognize your cells as been foreign and attacking them. So the interferons are driving the inflammation, they're driving the B cells to produce autoantibodies. You're getting that horrible sickness feeling, that tiredness, that slammed by a bus feeling. And so they're a very, very, very good target for treatment. And let me just show you, that was actually for something else, but it actually fits here. I mean, in the context of lupus, the interferons are the enemy within. They are the things you want to stop so that you can switch this off. Now, there are very many other aspects of the immune system that can be targeted. The interferons are one, though, that a lot of effort has gone into and is still going into for treatment. And so in a normal, healthy individual, one of the things that happens in your bodies all the time is your cells are dying, right? Cells die. There's normal turnover of cells all the time. And when a cell is dying, basically it's recognized by a cell called a macrophage, which contacts it, engulfs it, eats it up, and gets rid of it. And the reason it does that is to make sure that none of the proteins or the DNA or anything inside that cell gets seen by the immune system. Because your immune system has learned to recognize, has learned not to recognize your own cells and proteins. If your own cells and your proteins within those cells are around too much, then they're going to be recognized by the immune system and targeted. So, but in lupus, you've got these interferons. And what happens is the macrophage can't recognize those dead and dying cells anymore. So the dead and dying cells now are around so that they can be recognized by the B cells, and now you're producing all of these interferon or antibodies. And the antibodies can go and bind to your tissues. And if they bind to the tissues and stick there, then basically that's going to activate your immune system and you get tissue destruction. So that's the process that's going on in lupus, and how the lupus patient immune system is changed, it's altered, and predominantly by these interferons. So, we're going back to my little cartoon. But we have all these ways now. We know so much about the immune system in lupus. We really do. And every week there's a new paper. And there have been some really fundamental findings in the last 5 years around this disease. For example, these guys here, neutrophils, they make up 40% of your immune system, your blood cells, your immune blood cells. And we used to think that they weren't really that important in disease. Now we know they're massively important, and actually they're producing a lot of the interferons in lupus, whereas before people thought it was coming from another cell type. So now we have a new cell type that we can target. But we have lots of ways of targeting T and B cells. So Rituxan for B cells, that's going to reduce the levels of autoantibodies being produced. You have methotrexate, Cellcept, things like that. They're going to target the T and B cells as well, because they're cells that are turning over in your body all the time. And then we have steroids. Steroids are I've been to so many conferences talking about chronic inflammation, and apart from their, if they didn't have the side effects they do, they are probably considered amongst the best drugs ever discovered, because they can just shut down the immune system. They shut down these cells incredibly effectively, and they reduce inflammation. But they're not drugs that you want to be on long term because of their side effects. And now we've got this knowledge that we can use to target the interferons. So people are making antibodies that can bind the interferons and knock them up. People are blocking the signaling downstream, because all of these proteins work by binding to the cell surface and signaling within. If you know what's going on inside the cell, you can block that too. So there are lots and lots of ways that these pathways can be blocked. And there's been 2 trials for anti-interferons recently with modest effects, and there's another trial that's ongoing with another anti-interferon that's showing much better promise. So things are looking up. There are new treatments being developed all the time. And my view of things, and rightly or wrongly, I'm not a doctor. I'm a researcher, and I do understand the immune system very well. But sometimes I forget about other things, such as risks of infection, when you block certain arms to the immune system. But, the one thing that one kind of fairly strongly held view is that the interferons are kind of in the beginning of this cycle. So if you can block the interferons, you're blocking this vicious cycle, and you're resetting that immune system. You're basically getting it all back to normal again. And that's where you want to be. You don't want to turn off the immune system. You just want to reset it. And that's where we hope to get to. So where is lupus research going? As I said, it's going very much in a personalized direction. What we are doing at our research in Cedars, and anybody who wants to contact me, please do. Our research is looking at the immune system in various different organs. in the disease, right? So patients that have nephritis, patients that have lung disease, heart disease, skin disease, what's different about their immune system? And when we find that out, can we develop drugs or use drugs that have been used elsewhere to basically treat that? I mean, because we're all changing our view of disease now. It's not going to be one drug that fits all. It's going to be a multitude of drugs that fit different pockets of patients. And so now we have to find that information out, develop the tests that can be done within your clinic, so that you can be treated with one drug or a cocktail of drugs that's going to target your specific arm of the immune system that's defective. The other thing that we're working on in the lab, and something that is very important, is why women? So women are 9 times more likely to get the disease, but when men get the disease, it's very severe in men. So there's something about the female hormones that's driving the disease, and there's something potentially protective for the female hormones, or something about the Y chromosome or the X chromosome that's protective, that basically means that it changes the severity of the disease. So one thing we're looking at the effect of estrogens in driving the interferon system, and what we find is in normal healthy people, estrogen has no effect, or it actually inhibits the immune system. And in lupus patients, estrogen is actually driving and exacerbating disease. So ways to block estrogen effects and estrogen signaling are also things that we're looking at. So there are lots of different things that impact on the immune system. Hormones, hormones from the point of view of sex hormones, but also hormones from stress hormones, things like that. So all of these are areas that we're looking at, in order to build a holistic picture and a holistic view of what's going on in the immune system in lupus. That's it. And thank you very much.
Maybe you could read can you read your question? Because there are tons.
Yeah, great.
One of your slides, macrophage.
Yes.
What does that exactly mean?
So it's a type of immune cell that's it's basically a cell that is one of your first-line responders to any infection or any threat, and its job is basically to gobble up and destroy any threats that it finds. It's also very important from the normal balance of your bodies as well. It clears all the dead and bad material in your bodies. We used to think of lupus as just a B-cell-driven disease, and it was all about the autoantibodies. But in the last maybe 5 years, work from a number of groups have shown that the B cells and T cells are really important, but they've been driven by these guys, so they're interesting. Very fundamental part.
Here's a question. Does genetic testing, like the 23andMe DNA testing, help to determine if we have an autoimmune disorder? That's a good question.
It is a very good question. I would say that we haven't been able to find a single disease that each one of you is carrying.
Sure. Oh, or here you want a wireless microphone?
Yeah, great. I like to walk up and see that. There you go. Great. So we haven't yet discovered one gene that basically says that you all have lupus. There's probably about 30 different genes that are found in different populations. So from the point of view, we still haven't got a genetic test that can say, yes, you have lupus, or no, you don't. One of the best ways that we can test it is actually looking for anti-DNA antibodies. So, when you go in, if they're fairly indicative that there's something going on with the interferon system. So it's looking at your autoantibody profile and, a conglomerate of maybe 4 or 5 different clinical findings that allow us. We still don't have that test, unfortunately, that allows us to predict that.
So where do TNF inhibitors fit into the lupus picture?
So they're very good. So the macrophages, back to your question, they produce TNF. And the TNF drives inflammation. And inflammation goes hand in hand with the interferons. The interferons are doing something slightly different. They're driving the macrophages to become more inflamed and produce TNF, more TNF. So the anti-TNFs are basically shutting off this arm of the response, and they're reducing the inflammation in your joints. So the interferons start the loss of tolerance, and then, the anti-inflammatories turn off the actual disease in your tissues. So that's a very good question. Thank you.
How can we block interferons or reset our immune system naturally, food or other natural remedies instead of meds?
I don't know. I don't know if that's going to be something. Okay, so let me back up. So there's a lot of research going on now about the gut, links between the gut and disease, right? And so people are now looking at the bacteria and the fungi that are in your gut for lupus patients to see if that links up with disease. And potentially we might find a bacteria or a fungi that's found in most lupus patients, and you might be able to relate that bacteria, the levels of it, with interferons. If you knock that particular bacteria out, maybe you reduce the interferons. We don't know. I mean, that's the honest answer to that. All we can do is keep doing the research to see, what parts of the microbiome, it's called, is helping to drive this disease. And there's very strong evidence in other diseases that are a little bit further along, like IBD is looking at bacteria and fungi in the gut and how that relates to disease. And they've got some very, very, very nice findings that's showing that one bacteria might be like the causative agent for it's kind of a big step to say that, but like they have one that's linked with IBD anyway. So maybe we'll get there with lupus.
You just answered a question, so thank you. I didn't have to ask it. About gut bacteria. Is there correlation with hyperactive or underactive adrenal gland and creation of interferons?
Nobody's looked at that. That's a very good question.
I'll save it for you.
Yeah.
Okay.
And actually, that's why I love these question and answer sessions, because, you always have a broader view of your whole bodies and what's going on with your disease than we ever would. So, yes, certainly that's something that should be looked at. Very interesting.
Okay. If you have enough knowledge to understand a research paper but did not help health professionals access, how can you keep up with the latest research?
That's a great question.
That is a good question.
I struggle to keep up with the latest research, and that's been honest. There's so much coming out all the time. Catherine, we were talking about doing more scientific blogs and kind of, writing more regularly for within Lupus LA. So, I think that's probably a good forum. Use people like me and organizations like this to help you keep you informed.
Actually, how many of you recently read, Dr. Jeffries did a blog post for us a couple weeks ago? How many of you, or did any of you read our blog? What was the time? Yeah,
I can't even remember.
Immunology. Where is our blog, first of all, you should all be getting the blog. It comes out weekly. We have people like Dr. Jeffries and Dr. Wallace and all sorts of other doctors and patient advocates and patients and writers and all sorts of people write for our weekly blog. Go to our website. On the masthead where all the drop downs are, it says blog. There's also like a slider image that says check out our blog. So you click on there and you sign up and then you get our blog. Or just go to our website once a week and you also get our blog. Or look on our Facebook or our Instagram or our Twitter. When the blog comes out, it's all out there. So please check it out. But
and the other lupus groups, so what's the merged group called now?
So the Lupus Research Alliance, which used to be the SLE, LRI, and ALR, they're all now one, called the Lupus Research Alliance. They also put a lot of stuff on their website.
So when anything new comes out, they're on top of it as well. So that's a very good place to keep an eye on what's new. And
we also we post and we put out all of their stuff. So if you somehow miss it on our stuff, they have it. If you sometimes miss it on their stuff, We send it out too.
And there might be a Twitter feed as well. I'm starting to learn what Twitter is. It's very good for keeping up what's going on with the election. That's what I'm finding.
That is true. I want to actually, we have a few more minutes. Can you explain why birth control doesn't work like pregnancy, since estrogen suppression plays a role in feeling better? I felt amazing when I was pregnant.
Yeah, there was a very, very big study done on this. This is a little bit outside of my comfort zone, but there was a very, very big study done on this that was called the WISE study. And they looked at birth control pills and also hormone replacement therapy for lupus patients and what it did for the patients. And although the patients reported that they all felt fantastic, and possibly to do with the interferon suppression, although we have no evidence for that, the results of this study came back saying that there was no difference. So it was research looking at patient-reported outcomes. So that had, from patients who were on either birth control pills or hormone replacement therapy and what it did, the positive versus the negative outcomes of it. Work this is something that I really, really, really feel very strongly about, that the estrogen system is interfering with the interferon system. And it's work that we're starting. I mean, I'm putting a grant in for it next year, a big grant. It's work that we're doing, and it's work that Lupus LA helped support. That we're doing a small amount of it now, but I really want to ramp that up because it's clear that you can see with lupus patients, your disease is most active, during the period of your lives where your estrogen hormones are most active, and then goes down again afterwards. And so there's clearly something going on, but really people don't know what.
Can interferons attack your teeth and gums?
They can probably help your teeth and gums get more, because that's an area where you're very vascularized, so there's a lot of blood that goes through. Any area that's very vascularized will feel the effects of inflammation more easily. Potentially, yes, it could make your teeth and gums more sensitive.
What is the relationship of interferons to cytokines? I'm not saying that.
They are a cytokine. So cytokines are. It's a good question. I try to keep jargon out of the talk, because it can be very confusing. But cytokines are proteins that are very much like hormones. They're the hormones of your immune system. They basically tell your immune system what to do and tell your body what to do in the event of either an immune infection or an autoimmune attack. So interferons are part of that hormone system for the immune system.
Okay. Are flares caused by inflammation? What is inflammation exactly?
I could give you a whole 40 minutes on inflammation.
How about a 1-minute answer?
So inflammation is basically your body's response to injury, stress, or infection, right? And in lupus and in other autoimmune diseases, the cytokines that drive inflammation are things like TNF, IL-1, right? So that's why you go on anti-TNF blockers. And what happens is that the cytokines make your bring in the macrophages and the neutrophils and the T and B cells, all your immune cells, to the site of inflammation. Your blood vessels get dilated, more blood comes in, more immune cells come in, but you also get more fluid in the area, and you get swelling, and you get that's why you get joint swelling. And that's associated with a lot of pain because there's increased pressure because of the increased volume that's there. And also and the one thing you want to be careful with inflammation. Inflammation is great. You hit your finger with a hammer, you get inflammation, right? You get stuck with a splinter, you get inflammation. But once the threat is gone, you want to basically turn it off and resolve it. And that's what's not happening in autoimmune diseases and autoinflammatory diseases. You can turn on the inflammation, but turning off the inflammation is where your bodies have a problem. And, In cancer, basically the cancer cells are shutting off the immune system. In lupus, we're basically trying to shut off the immune system. So now we've got all these new drugs that have been developed for cancer to turn on the immune system using these particular pathways. So, you'd probably have heard of PD-L1. It's a potent anti-cancer agent, but it's turning on the immune system. Now rheumatologists are looking at the same systems to see if we can use those same pathways to turn off the immune system. So there's lots of new things coming down the tracks that are going to be aimed to tweak the immune system so that you can reset it again.
Okay, last 2 questions. If you have more questions, get them to Catherine, and we'll do our best to get them answered.
And you can grab me outside either.
Or just grab her outside. Okay. For someone who has had her thymus taken out, how does the loss of it affect the immune system in lupus?
So your thymus is mostly active in your up to the kind of end of your teens. And by then it basically gets much smaller and it stops producing T cells. That's what your thymus does. It produces T cells. So depending on when you lose your thymus, when it's been taken out, that's the important part of it. So if you're, after your 20s, your late teens, 20s, and your thymus has been taken out, or even, younger, because you've got a lot of T cells that are already in your system. So basically you make 1 million T cells a day. And those 1 million T cells are coming from, when you're younger, they're coming from the thymus. As you get older, you've got T cells resident in different parts of your body that make those new T cells. So it shouldn't impact your immune system that much.
So the last question is, it's a little confusing, so I'm going to sort of break it down a little bit, which is the use of diet and diet monitoring or diet changes and helping to support the immune system.
I think this is a fascinating area. I mean, anti-inflammatory diets, they work, right? I mean, for some people, they really work. Fish oils, putting fish oils, I mean, there's scientific basis for why eating more fish is good for you. Because like the fats in fish, the omega-3s, can't be broken down to make things that drive inflammation. Because a lot of the inflammatory mediators come from your cells themselves. You have this fat membrane that surrounds all your cells. Those fats are broken down during inflammation to generate more inflammatory mediators, right? Things that are going to drive inflammation, drive the pain, drive the swelling, etc. And if you start replacing those fats with the fish oil fats, then that can't happen. So that's the scientific basis behind that. I have mild osteoarthritis, and I basically decided, right, that's it. I've got to try something because there's nothing for osteoarthritis, and it's nothing to what you guys go through. But I tried the anti-inflammatory diet. It did help my joints. I don't know what it's going to do when you've got much more systemic inflammation. There's not that many studies done on it, but people do say that it can help. So there is a scientific basis behind, the anti-inflammatory diets, and they're well worth looking into.
Thank you so much.
Thank you, guys. Fantastic.
So it is 10:51. It's 1:51. 1:52. It's almost 2:00 where we will end. But before we end, there are a couple of really important things we need to do. The first is, and I see some of you are doing it, so nice job. Take out the yellow form in your packet. You could put your name on it. It could be anonymous. Whatever you're comfortable with. We want to know what you thought about today. We want to hear your ideas for next time. A lot of the speakers that we bring and a lot of the topics that we talk about at patient conferences all come from your evaluations. So we're listening to you. We want to hear what you have to say. If for some reason you don't want to fill it out today and you want to fill it out at home and send it in, that's okay too. So if you could do that. The next thing is the raffle. And lucky you, there are a lot of people who left early, so your chances have gotten way better. And inside the bags, you want to bring the bags out? There are 2. There are DVDs. There's really amazing sunblock. that you can only get at dermatology offices that were specifically created for lupus patients. It's the best sunblock I've ever used. It's called Phoenix. It's really good. It's like $40 a tube. And then it's also got these really cool pill pouches, these sort of designer pill pouches that are like $50 each that are in there. So it's a bunch of Lupus LA gack, like stuff, shirts and footballs and all sorts of stuff. So it's good. So get your ticket out. And the first one that I am randomly picking, I didn't look because I'm being blinded by that light, is ticket number 154479. Woohoo! Yay! Come on and pick a random bag. What's your name? What is it? Caitlin. Caitlin won a bag. Good job. Thank you. All right. Yay, Caitlin. All right. The next one is 154564. 564. All right. We have a winner. Come on down. Or pass it out of Mac or something. Okay, so the other thing that I wanted to say is thank you so much for being here today. We couldn't do this unless you were here. Thank you so much for giving up most of your Saturday. I know some of you drove from really far away. So thank you. And thank you to Catherine for putting this all together. Yay, Catherine. And when you leave, if you would just please give one of the Lupus LA staff people your forms on the way out. And to get your car, if you're parked in valet, you have to have your valet ticket. It's like cash. If you lose it, you will have to pay. And you need to take the elevators down one floor to collect your car. And thank you so much. We'll see you next year.
And if you use translation equipment, please remember to return it. Thank you.
Yes, and please don't take the translation equipment home. No, I know, but you pick the car downstairs.
Pick it up downstairs. Should I turn the computer off?
No, leave it on.
Great. Thank you so much, Harold. I appreciate all your
All
help
right,
with
see
everything.
you next year.
Yes, thank you. Thank you. Thanks for coming. Yeah, nice. And I love learning more about your organization and all this good stuff you guys do. Thanks for all your support. I appreciate it. I'm glad you're able to come. Yeah. It's nice to see you. You too. Hope you have a good weekend.